Yeah, let me do that now. Yeah, I think it should work. I could see it's allowing me now. Can you guys see it or?
Yeah, it's okay now.
Perfect. Okay, perfect.
Let's start. Good evening and welcome to today's webinar. Kurdistan Health Summit is in collaboration with the Kurdish American Medical Association, is holding the first from a series of scientific seminars regarding updates of COVID-19. Today's seminar will be in coordination with the Iraqi Kurdistan Society of Anesthesiologists. My name is Rawand Kamaran. I'm physician, ENTist, and public relations manager of Kurdistan Health Summit. First, I would like to say thank you to all colleagues who are working on the front line battling against COVID-19 and to give our well wishes to all patients and loved ones who have been affected by the disease. This webinar will be recorded and shared after a few days, and you can also watch us and see us in Facebook Live at Kurdistan Health Summit page. I am delighted to be joined by experts of COVID-19, critical care setting, Dr. Abdulhamid Al-Dabbagh, consultant anesthesiologist, head of Department of Anesthesia and Intensive Care Unit, Howler Teaching Hospital, lecturer to undergraduate and postgraduate students in College of Medicine, Howler Medical University, and program director of Erbil Center of the Arabic Board of Anesthesia, Iraqi Board of Anesthesia, and Kurdistan Board of Anesthesia. And Dr. Haval Shuish, CCU intensivist, pulmonary and critical medicine. Dr. Haval is assistant prof at Tufts University School of Medicine, and he is also director of cardiac critical care and COVID critical care at Tufts Medical Center in Boston. I will start my first question with Dr. Abdulhamid. Dr. Abdulhamid, please, if you could give us an update of the situation of COVID in Erbil.
Hello. Yeah. Can you hear me?
Yes.
Yeah. Thank you very much for sharing me with this webinar. Good morning, Dr. Haval. Probably it's daytime at the States. The current situation really here in Erbil, especially the capital of Kurdistan, is, I hope this is the peak. I hope we don't see worse than this. The number of patients who have been diagnosed is around 500 people per day, and the mortalities today were 17, 10 in Erbil, and the others in Duhok and Sulaimania. And this is happening on daily basis. And because of the outbreak and peaking, it's the hospitals are not coping with the amount of patients or the number of patients who need admission to the hospital. And moreover, that a lot of patients have been taken care at home, and really we have a lot of problem going on with the oxygen supply for most of the governmental and even now the private hospitals. The situation has escalated since last month, let's say in the beginning of July, and this is the opposite that what was happening in the beginning of the outbreak in Iraq. We started to have a few patients back in February, and for example, up till the beginning of June, we didn't have even one single admission to the ICU. But after that, by the first, let's say 2 weeks of June, we started to get patients, and since then, the number of patient admission to the ICU increased, and the really the mortality is going up. And for each, let's say 10 patients admission to the ICU, we have only 1 or 2 patients who survive and get out from the ICU. from the severe cases. That's the current situation in Erbil. And as I told you, I hope this is the peak and we don't see the worse than this. Yes, Dr. Hawal.
Okay, Dr. Abdul Hamid, thanks for your short update. We will start with Dr. Hawal. Then later on, after his presentation, we can have a small discussion in between.
Well, thank you so much, Rawand, Dr. Rawand, and thank you so much, Dr. Abdul Hamid, for your update. You know, as Dr. Rawand said, special thanks to the frontline providers who are helping our patients back home. You know, I understand from Dr. Abdul Hamid that, you know, it is surging now in Erbil, and we all have experienced this in different cities, and when it happens, it really overwhelms the healthcare system, regardless of how well established is the healthcare system. So I really hope that things get better. You know, I will start by sharing, you know, what we know so far about the critical care aspects of COVID-19, and we have learned a lot through the last few months. Now, you know, some of it might not be exactly practical at home, but, you know, I wanted to share the latest updates in critical care, and at the end, we'll have about 15-20 minutes to discuss any questions and hopefully make it more practical and applicable back home. So, you know, we'll start just with giving you some background about COVID-19. As you know, about 85 to 90% of cases are mild. However, about 15% of patients require hospitalization and they develop severe pneumonitis requiring oxygen, and 5% of them require ICU, and the mortality tend to be high in those patients. Now, if you look, this is important because it gives you some idea when the patient will get worse. And I'm sure you guys, you have seen that usually it's the second week of the symptoms start. So, you know, usually the patient tells you, I had the symptoms about week 10 days ago. And that's when they get in the hospital and they get really sick in the second and third week. So that's just to understand the timing of the likely worsening of illness if it will happen. Now, you know, I just want to talk quickly about what risk factors put the patient at risk to having a severe disease, because as we said, most of cases are mild. As you can see, this is from New York registry. About 2,200 patients were looked at from New York City hospitals. And you could see that, you know, the risk of death with age, it increases significantly. So anything beyond 50, and as you go older, basically you have higher risk of mortality. Interestingly, we have seen this in our experience as well. Male tend to have more severe illness than female, and also active cancer, which is not surprising, and coronary artery disease. You could see that they had a higher risk of mortality. So all this is not surprising, but it just gives you some perspective of who you would expect to get sick. Now, also, as they get into the hospital, the initial presentation into the ICU, you could predict their severity based on some variables on their admission day to the ICU. So the PF ratio, the PA2 divided by FiO2 ratio, if it's lower, that gives you really higher mortality risk, as well as the SOFA score, the liver SOFA score, which is mostly driven by the total bilirubin, and the renal SOFA score. The higher it gets, the more likely to die from COVID-19, which is not surprising, as we know. This is, an observation which was found here that, that if you have a smaller hospital with less than 50 ICU beds, you tend to have worse outcomes than the larger hospitals, which, are more equipped and, they get the experience of handling COVID-19 patients. Now, this is important, initial question, and I will have my lecture, my talk in more questions format. And one of the questions which came up initially when COVID started was, is COVID-related lung injury, the acute respiratory distress syndrome, is it typical or really it's a typical form of ARDS? And that brought a lot of discussion in the critical care ward. And, you know, one of the leader in the critical care, Professor Gattanoni from Italy, basically felt that this syndrome is atypical than the usual ARDS we see with the flu. And, you know, his observation from the initial patients he had, that, you know, those patients had really normal compliant lung for most of the part. So their lungs weren't stiff and it was easy to ventilate these patients, yet they were very hypoxic. Most of patients who have acute respiratory distress syndrome, their lung is really stiff and it's hard to ventilate them. Yet those patients, he observed that they have mostly normal compliance. Now, you know, he described these two phenotypes, and you could see the higher one, the higher picture is a patient with a CAT scan, which shows really not significant lung disease burden. The lung parenchyma is not significantly diseased, yet you could see that the PF ratio is severely reduced. Anything below 100 is really reduced. And you could see the other patient he described, which is more the typical ARDS. You see that the patient has significant lung parenchymal disease, and their PF ratio is also low, but, you know, to similar degree between those two phenotypes. And this is something which, you know, triggered an interest, is severe oxygen requirement you find in COVID patients. Is it really not related to lung tissue damage, lung parenchymal damage, and it could be more related to vascular thrombosis or microthrombi in the vasculature of the lungs. And this is, you know, from the same paper Gattanoni described, where he described basically those 3 autopsies, and he showed this variable thrombus burden in small vasculature of the lung, slightly larger vasculature, and inside the arteriosus, the small arteries. And you could see that the endothelial here, it's also damaged, the vascular endothelial, and there is significant inflammation here. So, you know, one theory by Gattanoni is basically, you know, you do have significant vascular component and thrombotic component inside the vasculature of the lungs, which leads to perfusion abnormalities in the lungs. However, you know, as the pandemic moved from Europe to US, we observed different really phenotype, where what we have seen in New York, and that from New York hospitals, they described about 250 patients, and they could, you know, they described that the compliance, it's really low, which is basically about 28 to 30, which is very similar to what we see with the typical ARDS. So, you know, the American description of the lung injury, it was more consistent with stiff lung for the majority of patients. And you could see, this is from Boston, from neighboring hospital to ours. They basically described the compliance for their 67 patients, and mostly they had the compliance lower than 40, which basically just reflect the stiff lungs as well. So, you know, the question, is it typical or atypical ARDS? The field now is that it's likely a form of ARDS, which by definition is heterogeneous syndrome, but there is significant vascular component to patients who have COVID-related ARDS. This is an autopsy which was done for 7 patients, actually, in a neighboring hospital to ours, and they basically did 7 autopsies for COVID-19 patients, and they compared them to 7 matching autopsies for flu-related pneumonia and ARDS. What they found that the major pathology, it's what we call diffuse alveolar damage, which is, you know, what's seen in typical ARDS, even flu-related ARDS. However, what they have seen in those patients that there was more thrombosis, mostly microthrombosis. It was 9 times higher in patients who had COVID-19. And also the COVID-19 patients had more angiogenesis. So, there was more markers that there was a vascular involvement in those patients. And you could see this is some very nice pictures of electronic microscope for those autopsies where it shows the thrombosis within the artery. And those are, just a regular microscope. And this is 3D abnormalities in patients who have COVID-19 patients. So COVID-19 injury. So, in general, I think that is likely a form of ARDS with, significant percentage of patients have a stiff lung, but there is contribution of vascular injury / thrombosis, which lead to more oxygen dysregulation, more oxygenation dysregulation, and hypoxemia. Now, I'm going to go through this, and I would be quick to address each of those questions. And those questions came up as we cared for those patients, and now we have some evidence about this. I'm interested to ask Dr. Abdelhamid if you do have what we call high flow nasal cannula or CPAP. Is that available in Iraq?
Yeah,
Okay.
it is available. We have CPAP, we have also the BiPAP, and also we have the high flow nasal cannula in some of the hospitals, not all.
Okay, well, that's good, because I think it does have a role. We'll talk about, is there a role for high flow nasal cannula in COVID-19 patients? So just to give you perspective, as we started preparing for the pandemic, one of the major questions is if you provide oxygen with very high flow to the patient's nostrils, there was a concern that you might increase the risk of transmission of viral particles to the healthcare providers and to other patients. So there was significant controversy about the use of high flow nasal cannula in patients who had COVID-19 ARDS. And you could see that, the question to be answered about the role of high flow nasal cannula really depends on 3 factors. One, would it be helpful intubation, and you keep the patient on high flow nasal cannula and they basically get really worse to the point where you would intubate them, they would have a respiratory arrest, and that could basically lead to unfavorable outcome and mortality in those cases. Now, there is something to do with the risk to the patient, which is concept called patient self-inflicted lung injury. And this is a concept which basically has been described in the critical care literature, not fully agreed on by all experts, but most of experts believe in this entity, that if you leave the patient in respiratory distress and they breathe really at fast rate and high tidal volumes, that they could basically injure their own lungs, and it would be too late to intervene on them, because at that point, you would basically have a fibrotic lungs. So, you have to be careful. High flow nasal cannula, there is a benefit for it, but you don't want to delay the intubation if the patient is getting really worse. Is there potential risk from transmission to providers? Most studies are reassuring, actually. So, if you use high flow nasal cannula, it's considered what we call aerosol generating procedure. So you want to basically use adequate personal protective equipment. And what we do at our hospital, we use a mask on the patient face and nose. So we put the nasal cannula as a high flow nasal cannula, and we put mask over it. And that's what's recommended now as well throughout US. So, this is an algorithm which I have to put disclaimer here. This is really based on what we felt it's appropriate, but there is no evidence to back this algorithms that it would improve outcomes. But the question is when to intubate patients who have COVID-related ARDS. And, if you have somebody really dropping their oxygen very quickly, or they have a multi-organ failure where they are in renal failure, liver failure, they are in shock, significant shock, it's best just to go ahead and intubate the patient. If you have none of those, it's very helpful to try high flow nasal cannula or CPAP. There is something called helmet CPAP, where the interface for delivering the pressure and the oxygen, it's like a helmet where the patient wears it over holds their head. It's used in Italy very often, and in Europe. In US, it really doesn't have much, doesn't have much of affinity for it. So, we haven't been really using it. We use mostly the high flow nasal cannula. And if you try the high flow nasal cannula in those patients and the work of breathing is suppressed, the patient's not really working hard to breathe, and their oxygen saturation is relatively good, 88% on 60 liters and 60%, you can wait and hold and basically not intubate this patient and just continue with the high flow nasal cannula. And what we have done here, and it has been encouraged throughout US, is encourage self-pronation. So have the patient sleep on their belly, or even during the daytime, try to spend a couple hours on their belly rather than laying spine, because that could improve the ventilation perfusion matching, and it improves their dyspnea and their oxygenation. So, why this is important, and this is based on theory by Gattinoni, the expert from Italy I referred to. Gattinoni and Marini, they are really well-respected experts in the ARDS. And what you could see, this is what we call the ventilation-induced lung injury vortex. And you could see it start with the patient low oxygen saturation, which could lead to the patient taking deep breath. Now, if you don't suppress the deep breath and the vigorous inspiratory effort, the patient could get what we call ventilation-induced lung injury, which causes more strain on the vessels. It causes more capillary leak and endothelial leak, and you have more edema, which lead to more basically lung injury, and what we call the healthy lung, the baby lung shrinks, and that would basically worsen the vortex. Now, if you intervene here early on, and not let the cycle go on, and provide high flow nasal cannula or CPAP, and you decrease the inspiratory effort successfully, you could basically just sit on the patient and hopefully nothing bad will happen. If you're not successful in breaking this cycle, you likely have a late intubation and worse lungs than what you started with. Now, if you cannot decrease the inspiratory effort by applying high flow nasal cannula, probably you should move on with early intubation. So, this is something which is more geared towards critical care folks, is, what we call the positive end expiratory pressure. So as you ventilate the patient, we usually leave the pressure at the end of expiration to keep the alveoli open. And in general, in severe ARDS where you have stiff lung, we utilize high PEEP strategy, where basically we use higher PEEP to prevent the alveoli from collapsing. Now, most of ARDS patients, as we said, they have stiff lungs, so their lung is really not compliant. However, remember that ARDS is very heterogeneous syndrome, and remember that in some COVID patients, as Gattinoni described, the lung actually is really not stiff. They are very hypoxic, but their lungs is really easy to ventilate. And that's why it's important not to use high PEEP for everybody, because if you have a very compliant lung and you use high positive end expiratory pressure, what you're turning the lungs now to really non-compliant lung. Because remember, if you think of a balloon, the first part of the balloon, when you're inflating the balloon, it's the hard part. Then in the middle, you have a sweet spot where the balloon becomes compliant. If you inflate the balloon too much and you overextend it, now you're really decreasing the balloon compliance and it becomes really stiffer. So you want to find that middle sweet spot based on how compliant is the balloon, and you don't want to overextend the compliant lung because then you will turn it into non-compliant lung. So, what's this important about is, you have to be thoughtful about, is your patient who you're seeing in the front of you and is on mechanical ventilation, do they have a compliant lung, what Gatanuni calls the L phenotype, which is low elasticity, or is it a non-compliant lung, which is the H phenotype? And basically what you do, you just measure the compliance at different PEEP value, and I could share our protocol with you guys at the end. And based on knowing, is it a L phenotype or H phenotype, you could basically target your therapy by using lower PEEP or higher PEEP. This is something which is really very specialized, but we could share this protocol at the end with Dr. Rawand, and he could distribute it to the group if they're interested. Now, let's move on to another question, which is basically, do you prone the patient? And as I said, proning is having the patient laying on their belly. And that has been a therapy which has been proven to be helpful in other types of ARDS as well. This is a study called PROSEVA study, which was published in 2013 in New England Journal of Medicine. It was done mostly in Europe and France. It was multi-center trial. But what they did, they basically took patients who had a moderate to severe ARDS. So they had a PF ratio less than 150, and they assigned them either to proning group or supinated group. So the proning group, what they did, they basically put them on their belly for 16 hours a day and bag on their bag for 8 hours a day. So what we typically do around 4 p.m., 4 afternoon, we flip them on their belly. We keep them all the night on their belly, and at 8 in the morning, we flip them back to their bag, basically. And, there was improvement in mortality, significant improvement. It dropped mortality from 32% in this trial to 16%. So it cut it in half. And this is typical ARDS, and clearly it helps with patients who have COVID as well. No randomized trials have been done, but all the observation confirm favorable response to proning. So when do we prone? We prone based on the study done, PROSEVA. If the PaO2 divided by FiO2, if it's less than 150, we definitely prone those patients. And we usually stop proning if the PF ratio is above 150, sorry, I missed this one, on a arterial blood gas 4 hours after supination. Now, it is low risk procedure, but as you can imagine, if the patient has an airway, has a tube, and has a lot of lines, and they're very sick, as you flip them, things might go wrong. And, the more you do this procedure, the better the better your nurses and your doctors will get good at it. So, initially, as the COVID started, we weren't really as efficient as proning patients, but at the end of the pandemic, we really got good at it, and we were proning almost everyone. Now, paralytics, and I think you guys, would have that available in Iraqi Erbil as well, in Iraqi Kurdistan. We know that, sometimes paralytics have been used in patients who have very severe acute respiratory distress syndrome. And the thought is to have the patient synchronized with the ventilator and hopefully have less oxygen consumption and less lung injury, so better outcomes. But this has been looked at very carefully in a big trial, which actually were part of at Tufts. And that trial was published in 2019. I took part of this trial, and what we discovered that if you routinely use paralytics for the first 48 hours of ARDS, it does not help patients. So, we only use it if the patient is really looking uncomfortable and not breathing well with the ventilator. You could use it as needed, but not really use it as routinely, because it doesn't help, and it could lead to potentially to weakness, even though the studies haven't really shown that. Now, again, I'm not sure if this is available. We could, at the end, ask Dr. Abdelhamid if this is available in Iraqi Kurdistan, the inhaled pulmonary vasodilator. And there are two major ones which are used here. One's called inhaled nitric oxide. So you basically give the pulmonary vasodilator through inhalation. And as you do that, you basically vasodilate the lung capillaries, which are being very well ventilated, because if they're not well ventilated, you wouldn't get it through the inhalation. And then if you vasodilate those pulmonary capillaries, you will have a very good matching between your ventilation and perfusion, and you could improve your gas exchange, your oxygenation. So, we really didn't use it much because proning was very effective with improving the oxygenation. So we didn't use it much in our experience, but it's something, if it's available and the patient has really severe hypoxemia, it could be thought of. There is some discussion that it might kill the virus itself if you use it inhaled, but this hasn't proven, and it's still being looked at in trials, including our center is looking at it. The one disadvantage with inhaled pulmonary vasodilator is that, yes, it improves the oxygenation. You could see that the first 24 hours, the oxygenation significantly improved in the nitric oxide group, but by day 3, it goes back exactly to placebo level. So even though there is improvement, it's usually transient, and it doesn't last longer, and it doesn't translate to mortality benefit. So you really don't get enough benefit from applying pulmonary vasodilators, inhaled pulmonary vasodilators. So one question comes up is when to extubate, and you do your routine things as you do, I'm sure, in Erbil and other centers in Iraqi Kurdistan. Once the patient lungs start improving and they have lower FiO2 requirement and PEEP requirement, the positive index respiratory pressure requirement, you could basically start exercising them and see if they could come off ventilation. One thing which you have to be careful, if they are still on very high oxygen requirement, do not wake them up because they're not ready. And if you do wake them up, they probably will develop more lung injury. So try to keep them asleep until you basically have reach a lower level of FiO2 and PEEP. Now, these are interesting data we recently got, and we should answer those questions. And I hope you guys have this available, because this is the one drug which has shown in a critical care COVID patients that it improves survival. And this is dexamethasone, which is, as you all know, it's a steroid drug. And this study was done in Britain and UK, and they did a really nice job. It's called recovery trial, where basically they had different arms of the study, but the important arm which showed the benefit of dexamethasone compared to placebo group, around 4,000 patients, so huge study. It was done through the NHS. Comparing it to 2,000 patients who got dexamethasone. And what you could see, if you compare all of them, there was a mortality drop, significant mortality drop if you compare dexamethasone to usual care. Now, let's break it to patients depending on the severity. So patients who were ventilated, so your patient who's in the ICU, if you give them dexamethasone, only 6 milligrams, so not much, 6 milligrams per day for 10 days, you drop the mortality from 41% to 29%. So huge drop mortality with a very cheap drug, which is easily available without much side effect. So you're dropping it from 41% to 29%. And this has really changed how we did things. And, in Tufts, we routinely use dexamethasone for all patients who are intubated and also patients who are just on oxygen. So somebody in the floor, and a regular ward, if you call it, or floor, they are on just oxygen. If you use dexamethasone, you do drop the mortality from 27% to 23%. Not a huge drop, but at least you drop it by 4%. So it's definitely something which is helpful to those patients. Now, if the patient does not require oxygen at all, so the patient is not on oxygen or the patient is at home, and this is really important, there was no benefit of using dexamethasone at all. In fact, there was a trend towards worse outcome if you use dexamethasone. So far, if you take anything out of this discussion, we know that dexamethasone really helpful for patients who are mechanically ventilated, helpful for patients who are on oxygen, not helpful for patients who are outpatient or not on oxygen. This is just a little bit of background about other ARDS patients. This was published in February 2020 in Lancet. And it was a Spanish study, done in Spain, where they looked at dexamethasone in other ARDS, just typical ARDS, and they compared dexamethasone to no dexamethasone in around 140 patients in each group, and it did drop the mortality by 15%. Those were patients who had moderate to severe ARDS, and their mortality dropped by 15%. So, even in typical ARDS, the mortality has dropped, and I think dexamethasone really has a role in patients who have COVID-related ARDS, as studies have shown. Now, remdesivir, I don't think it would be available yet outside of US, but even in US is not easily available. I have to tell you, as we had our surge, it wasn't very easily available throughout all centers. Thankfully, we got it to our patients, but remdesivir, the signal you get from remdesivir is not as strong as dexamethasone. The help you get from that is very limited. And actually what it has shown that it decreases the time to recovery. So you get out of the hospital sooner, but there is no solid data that it decreases mortality. And interestingly, remdesivir, the antiviral medication, it helps. If you look here, if you focus on the lower part of this graph, patients who were invasively ventilated or were on receiving high flow oxygen, high level of oxygen, the benefit was not shown here. Now, maybe the study was small, the subgroup was smaller, it was around 200 patients, but you could see if you're very sick, either mechanically ventilated or on high flow oxygen, there is no data that remdesivir would be helping you. Dexamethasone definitely would be helping you. Now, if you just on oxygen, like on the ward, just on a couple liters of oxygen, there is a benefit that remdesivir would likely improve your recovery time, and you would likely be leaving the hospital sooner, not extubated. Those patients will not be intubated to start with. Now, if you're not receiving oxygen, it's not clear. Maybe it's helping, maybe it's not, but we don't see it from this study. Good. So now this is probably not going to be available easily outside of the developed world. It's IL-6 inhibitor, so it's something used mostly in rheumatologic diseases like RA or rheumatoid arthritis or lupus. And, really, we don't know if it helps. We used it as part of clinical trials initially when COVID-19 started, and we used it in the ICU as part of this trial. We took part of Sirolimus trial. We recruited about 35 patients into this trial. And what you could see is that if you compare, this is just prelim data, but if you compare the placebo to patients who got high dose Sirolimus, which is one of the IL-6 inhibition, which is basically immunomodulator, you could see that the combined outcome, death or still on ventilator, did it drop significantly from 55% to 32%. But if you look more carefully to each outcome separately, you could see that the death is actually very similar, 27% versus 23%, not statistically significant. And most of the benefit came from the ventilation need, which, we don't know if those ventilated patients would end up dying or not. So really, this study was not really favorable. And, we don't think that there is trial ongoing, but the signal wasn't strong enough to suggest that we should be using it off-label. Now, this is something I would be interested at the end to hear if it's at all feasible in Iraqi Kurdistan, because it might have a value in some patients. And this is what we call convalescent plasma. And, the concept is very, logic that, if you do have patients who have recovered 4 weeks after their illness, and if you take their serum, that probably they have antibodies, and hopefully they neutralizing antibodies, and hopefully they are at enough titers to basically help the patients who is currently infected if you give it to those patients. However, as you could see, I said hopefully quite a few times. So we don't really know if the patients who recovered have, enough neutralizing antibodies to help the patients who's currently infected. And the study, unfortunately, this Chinese study, which was well designed, was terminated early because China contained the virus quickly. So they terminated the study after recruiting 100 patients, 103 patients, 103 patients. And initially, they were thinking to enroll 200 patients. So, the study wasn't really powered. However, if you look at the, recovery rate and you try to tease it out by, if you look at all patients, there wasn't statistically significant evidence that convalescent plasma helps. If you look at patients who have severe disease, meaning patients who are on oxygen, but not on mechanical ventilation, so not very severe disease. So if you exclude the life-threatening patients and you just look at the patients who are on oxygen, there was basically statistically significant improvement in patients who got convalescent plasma. And they improved on the recovery scale quicker. It was around 4 days quicker, and they had less mortality. It dropped from 90% to around 67%. So, the survival improved from 60% in the control to 90% in the convalescent plasma group if you have severe disease. If you're too sick and you are on ventilators, the convalescent plasma did not help based on this study, but as I said, it was underpowered. It was kind of terminated early because China did not have any more cases. So, even though this study, the JAMA article, did not show statistically significant benefit of convalescent plasma, that's what I mean by CP, sorry. The study was underpowered and there was a signal toward better trend, trend is spelled wrong here, in the CP group. So helpful signals that earlier is likely better if you have less severe patients, so the patients who are on oxygen but not mechanically ventilated, they do well. And the other important thing from this trial that it actually showed that the side effects of the convalescent plasma were very minimal. So, there weren't many allergic reaction cases, there weren't cases of transfusion-related lung injury or transfusion-related circulatory overload cases. So, very minimal side effects. So overall, I think it has a value. Now, anticoagulation, just so you guys, the thromboembolic incidence, so patients who are diagnosed with pulmonary embolism or deep venous thrombosis varied significantly based on studies. More common in European studies than US studies. So if you look at the initial Dutch study, they reported 35% of their patients, of their ICU patients had a PE. The French reported 17% of their patients had a PE. Down to next to our hospital, this is the Brigham and MGH, reported only 7%. So you could see very variable rate. And our neighbors actually in the city reported 6% bleeding risk, major bleeding risk. So you could see it's very variable incidence. And we don't really have a solid studies to show the benefit of anticoagulation, but some retrospective data from Mount Sinai shows that if you receive mechanical ventilation, about 390 patients who were on ventilation, and they received anticoagulation, they're basically, mortality was better compared to the ones who did not receive anticoagulation. So there is a signal based on retrospective studies. What's very important that everybody who has a COVID-related illness in the ICU should get prophylaxis, at least prophylaxis dose of anticoagulation if they don't have contraindication. And you should always think of a PE and DVT on those patients if they have signs. And I'm not sure if you have D-dimer available to check in Iraqi Kurdistan, but some protocols use D-dimer to basically guide your intensity of anticoagulation. It's controversial yet, but actually our hospital adopted a protocol which uses D-dimer, integrate D-dimer in the guidance of the intensity of anticoagulation we use for those patients. So this is a tough guidelines, and I will share it with Dr. Rawand, and he could share it with the group at the end. But everybody gets prophylactic anticoagulation if they have higher risk, basically signs like very quickly climbing D-dimer or high CRP or ferritin. Not sure if those are available to check in Iraqi Kurdistan, but if those are increasing, then you should use higher doses of prophylaxis. We usually use, a low molecular weight heparin in most of the patients. We use enoxaparin, about 40 milligram twice a day, unless they have a kidney disease. And these are some other, I will share with Dr. Rawand. As I said, it's based on, the experts' opinions that we developed this protocol. So this is just the last slide that, even though it's very hard to take care of those patients, this is our prelim data from Tufts. And, it took a lot of effort to take care of those patients. And, we had a data on 134 vented patients in our hospital. And, thankfully, our mortality was only 26%, which, compared to other literature, it's much lower. We will try to publish our data soon, but, it is very, resource draining disease. But, if you put a lot of effort in those patients, and hopefully if you have resources, I know they limited there, but if you do have resources, hopefully, some of those patients will do well. Now, I just want to just give special thanks to our organizations, Kurdish American Medical Association, and special thanks to Dr. Abdel Hamid Dabbagh, and Dr. Rawand for organizing this. Thank you so much. I'm honored to be, with you guys on this webinar. And as Dr. Rawan said at the beginning, special thanks to the frontline providers. They put their lives at risk to take care of those patients. So thank you.
Okay, thank you, Dr. Haval, for your well-detailed presentation. I would just like to go back to Dr. Abdul Hamid. If you have any question to Dr. Haval, any discussion?
Thank you very much, Dr. Haval, for your nice presentation. I think you asked me one question whether nitric oxide is available in Kurdistan. No, it's not available. That's why we are not using it, and we have no experience with it, really.
Sure.
I have some questions. First is about the, as it is, we know it's a thromboembolic phenomena. There's intravascular thrombosis in the pulmonary region mostly. And we are using anticoagulants also here in Kurdistan. And from the literatures, we know that the thrombus is it's not an ordinary thrombus. It's very rich with platelets and megakaryocytes. So is there any role of using antiplatelet along with anticoagulants?
Well, that's a really good question, Dr. Abdul Hamid. As you said, this is the assumption that this is, a unique type of thrombosis, and this question has been raised. Is there, a advantage of adding antiplatelet to the anticoagulation? And most of the guidelines have not suggested that. I'm not aware of studies of additional adding aspirin to anticoagulation. Most of the studies really, if you do have a very critically ill patients with high D-dimer or high risk of hypercoagulability, we treat them with therapeutic anticoagulation, and typically we haven't added really aspirin into the regimen. That's currently most of the recommendation do not add antiplatelet on top of that.
My next question is regarding Decadron, and there are some centers which they use methylprednisolone. Does it make any difference using any one of the steroids?
That's a very, very good question. I think, the study, if you want to be purist, the study with the dexamethasone ARDS study, the one published in Lancet even before the recovery trial, which showed benefit in non-COVID ARDS, and that recovery showed the COVID ARDS benefit. They were all done with dexamethasone. Now, potentially you could extrapolate that to methylprednisolone, and usually the conversion is about 32 milligram of methylprednisolone, so salmeterol or methylprednisolone 32 milligram per day. That's equivalent dose of milligram of dexamethasone. The one advantage with dexamethasone, which I want to highlight, is that it has a longer half-life compared to the prednisone and the methylprednisolone. So it potentially stays, the activity of it's more homogeneous throughout the day. And some experts basically suggest if you do have dexamethasone, just to stick with dexamethasone, because the pharmacokinetics of dexamethasone is more favorable for homogeneous present throughout the day. So that's why, if you do have it, I would suggest using it. If you don't have it, definitely I would use methylprednisolone 32 milligram a day or prednisone 40 milligram a day.
Thank you very much. My next question is about the convalescent plasma. Is there, when is the best time to give the convalescent plasma? And is there any role if we are later than 2 weeks?
That's a very good question, Dr. Abdul Hamid, because I honestly don't know if we know the answer, but we do give it in patients who have, if you could give it earlier, you should give it. The Chinese study I referred to, the one which was underpowered, they give the convalescent plasma late in the course, so at 30 days of the onset of the disease. and or the onset of the symptoms, and they still found benefit in patients who were on oxygen. So I would definitely give it if you have it available, even up to a month into the disease and the symptom onset. If you have it available, I would give it, and the earlier you give it, the better. I think that's what I would say. But the Chinese studies, they weren't really giving it early. They were giving it a month into the disease, mostly because they didn't have many patients recovered yet, because it was early in the pandemic when they did the study.
Thank you. And the other question is also about the convalescent plasma. For the donors, do you at the States, you let's say after 4 weeks, you tell them to go and give their plasma, or you do, let's say, test for titer, how much is the titer, and then you tell the donor to go and give it?
That's a very, very good question. In US, they don't basically, as of now, they don't actually require a titer confirmation to donate your blood to be considered convalescent plasma. So basically, you get your illness, 4 weeks after that, you are considered eligible to donate your plasma, and you don't need a titer confirmation to take your plasma to give it to a patient, And also the quantity of the antibodies, as I said, that's one limitation, that we don't know if the quantity of the antibodies is good enough. And just practically speaking, Dr. Abdelhamid, we have given patients who were sick, and if we had enough plasma, we have given, instead of 1 unit, 2 units, just to make sure that they get enough antibodies, because we didn't check the quantitative assessment of the antibodies.
Thank you. The other question is about NAC, N-acetylcysteine.
Sure.
I don't know. I had a very hard day today, so I didn't see that you mentioned anything about it.
Yeah. We haven't used it at all. I'm not aware of any, literature supporting its use. And a lot of things have been tried, as you know, but there isn't really any evidence beyond what I mentioned here that it helps. The hydroxychloroquine, also a lot of discussion has happened, but really the data does not support its use at all in mild or severe cases. So we don't use it at all. Initially in the pandemic, we used it, but we completely stopped using it for any hospitalized patient or outpatient.
Yes, and what about in the severe cases? Have you used ECMO for severe cases? Yeah.
Yeah, I actually had an ECMO slide here, but I didn't want to elaborate on it. I thought maybe it's not available there, but we have used ECMO for 4 of my patients. And, in United States, I'm part of a, kind of national conference. We get in and we discuss the ECMO cases for COVID. It has been used for at least 1,000 patients in US now. And the outcomes are actually reasonably okay. About 55% of those patients have been discharged alive from the hospital, and 45% have died. So it's very similar to, our typical ARDS where they require ECMO. So, the outcomes are good, but it's very, very resource intensive, as Dr. Abdelhamid, even for our system, when we had 4 patients on ECMO, it gets the system, it challenges the system.
Thank you very much. I may have some other questions, but I don't want to, let's say, take all the questions for myself. I want the audience also, if they have questions, to participate.
Yeah, and Dr. Abdelhamid, I'm really pleased to have met you through this, and potentially we could connect later on through Dr. Rowan to keep the connection going, for future.
Yes, of course, sure. Yeah. I'd be delighted.
Thank you.
Okay, thanks. Thank you a lot. We have some questions coming from chat. I'd just like to share with you, Dr. Abba. The first is from Dr. Aras Hassan. She's asking about herbal medicine and any relation that, because in Kurdistan we have a Kurdish jatra is named. By boiling and inhalation, the oxygen will increase. So she's asking why it's not used there.
Well, I'm not familiar with any, data to support its use. Obviously, if patients do feel better, it might, help them, kind of subjectively. But I'm not really aware of such herbal medicine to improve the oxygenation level. A lot of the data out there, it's basically based on personal experience, which hasn't been really translated into, actual evidence-based,
Okay, and the second is from Khatuzin Hassan. When can use dexamethasone? Only should be used for the patient with oxygen? Could it depend on SpO2?
Yes, so that's a very good question. So, basically, it is given in any patients who requires oxygen, so either just nasal oxygen, any type of oxygen, or mechanical ventilation. The benefit is more in patients who are mechanically ventilated, but even patients who are on oxygen, they benefit from dexamethasone. So and any patient whose oxygen saturation is less than 93 on room air would benefit from from dexamethasone, sorry.
Okay. And from Reen Ziad, if the patient recovered since more than 4 weeks, is their plasma effective?
Can you say that again? If the patient recovered more than 4 weeks?
More than 4 weeks. Is there
the plasma effect? Yeah, we think so, actually. The effect of the plasma is likely to stay from 4 weeks to 3 months. So here they take the blood from recovered people from a month to 3 months. So in that period, you probably have effective antibodies. So if you have recovered, I would encourage you to donate.
From Khalat, is there any benefit of azithromycin?
Yeah, so that's a good question, and if you remember the trial I mentioned, the recovery trial, one of the arms was azithromycin and it was terminated because it didn't show any benefit. And also recently in New England Journal of Medicine, they published an article for patients who had a mild hospitalized cases of COVID-19, and they had either hydroxychloroquine or hydroxychloroquine plus azithromycin, and it showed no benefit versus placebo. It showed no benefit compared to placebo. So, there isn't really any benefit. I see on social media, at least, I'm from Syrian Kurdistan. I see that, some of my friends post if you have a mild case at home to use, azithromycin at home. There isn't really any benefit in the literature to suggest that.
Okay, and from Lilian Azala, any role of inhalational corticosteroid like budesonide?
Yes, that's a very good question. The only role for inhaled Pulmicort or budesonide, or any type of inhaled steroid would be in patients who have airway disease like asthma, and they have bronchospasm, and those patients could benefit from inhaled corticosteroid, but it doesn't really help the COVID-19 pneumonitis. So if you really have a lung inflammation related to COVID-19 and you are on oxygen or on mechanical ventilation, you should use systemic steroid, not inhaled one.
Okay, and Dr. Rabin Ahmed, he's board member of Kurdistan Health Summit also. He's asking, is there any guideline to depend on CRP while giving dexamethasone?
Yeah, that's a very good question. The studies, the recovery trial did not really see an association between the CRP level and the benefit of dexamethasone. So, the benefit was present throughout all patients who were on oxygen or mechanically ventilated. So, the CRP guidance would not be recommended in those cases. It's a very good question because you would think if you have a lot of inflammation, your CRP would be elevated and you would have a better benefit, but that hasn't been shown that way.
And Hannah Haurami is asking, what about of those SpO287, but not Disney? They need oxygen or not?
Yeah, that's a very good question. It's interesting because some of those patients, they would have a low oxygen level, but really they not short of breath, or they don't really look short of breath. We call them here in United States, we used to call them happy hypoxic patients, because the oxygen level would be low, but they're smiling and they look fine. And, the low oxygen level is not big driver for dyspnea. So, it's not very surprising, but, we usually recommend using oxygen to target O2 sat 88 or above, So, 87, it's kind of on the cutoff. Probably if you leave the patient, nothing bad will happen. But, it definitely needs, it warrants a close observation and likely will need oxygen at some point,
And Diyar Khoshnaw, when you can give plasma, do we have any recommendation or parameters?
Yeah, so I think, as we mentioned earlier, for plasma, any patient who is on oxygen or hospitalized, I would give them convalescent plasma. So any hospitalized patients, earlier is better if you could find it earlier in their course. If you could get matching convalescent plasma for them, up to a month as well. Their illness, I would still give it to those patients, So we, as I said, the studies, what we have learned from them, that the side effects of convalescent plasma is minimal. There isn't really much of side effects. So we liberal with giving the convalescent plasma for those patients.
Okay, I think this will be the last question. Last Azad, in the US, beside of radiological imaging, do you just depend on PCR for the confirmation of COVID or some other blood tests like CRP and ESR?
Yeah, no, that's a good question. We really depend on the PCR, the nasopharyngeal swab PCR for confirmation. We have had maybe couple cases, maybe one or two I was involved in when the PCR was negative. The radiologic findings were very suggestive of COVID and the history, and all the inflammatory markers were elevated. So we, the history and the radiologic findings kind of, led us to believe that those patients had COVID despite negative PCR. But for most of the time, the confirmation is done by PCR. Nasopharyngeal swab. Somebody else is asking, actually, any patient in your center developed any surgical condition needing operation? Yes, actually, we had one case, a young gentleman who had bad COVID pneumonia who ended up on ECMO, and he had very bad ileus. That his abdominal pressure, his intra-abdominal pressure were too high because he developed such a bad ileus that we had to open his belly, and we believe that the ileus was mostly related to the high level of opioid he was receiving for sedation. But other than that, we really haven't seen many surgical conditions.
I think Dr. Abdul Hamid has a question.
Sure, absolutely.
Thank you very much.
Sure.
Well, I think our friends, let's say, asked all what was on my mind. I was just asking about the time of intubation. You said we have to keep them on a high flow, or let's say CPAP mask to most of the time, and we can delay the intubation. And we are doing the same thing, but what happens that we are keeping the patients on the verge, and suddenly they just collapse. And because of here in Erbil, we are having too many patients, and all of a sudden we get a collapse. And when we start to intubate, what we see is, as you said, the lung is so compliant, where I am inflating the ambu bag, and the chest is very well compliant, and the saturation is not going up. I was thinking of, let's say, to do early intubation, earlier than what we are doing now. You know, it's a new disease, and we have very little experience with it. What do you think about this?
Yeah, no, that's a very good, you know, this is something we all talked about, and I think, you know, it's a dilemma. And, you know, I think what you're referring to, Dr. Abdelhamid, is, you know, kind of leaving the patient, you know, on CPAP or high flow really to late stages. And when they need intubations, they just basically collapse, and they could have a respiratory arrest. And that's something definitely we would like to avoid, and definitely the intubation should be done earlier than the point you're referring to. You know, the question, how early is early and how late is late, and that's basically one of the, you know, dilemma we also face. But, you know, for us, if the FiO2 is above 60%, or the work of breathing is high, despite applying of CPAP, we just go ahead and intubate. So, you know, either or, if you do have a higher work of breathing, or the oxygenation is still not optimal with FiO2 60%, we do go ahead and intubate, because at that point you don't really have a margin. If you leave the patient on FiO2 100% and their oxygen saturation is 87 and they're breathing really hard, then, you know, once you intubate them, there is really high risk for collapse and, you know, respiratory arrest. So I do agree with you that, you know, it should be done earlier than the point you referred to.
I think Dr. Abdelhamid is disconnected, maybe.
Do you have an explanation for those? Rate is not high, and their saturation.
Sorry, Dr. Abdelhamid, I think your voice was breaking. Can you repeat your question? Yeah, I think I cannot hear Dr. Abdelhamid. Can you guys hear him?
Yes.
Oh, sorry, I missed your question. You know, can you repeat it, Dr. Abdelhamid? The connection was bad for a second.
Yes, my question was about the happy hypoxic patients. I even see that their pulse rate is not high. They are hypoxic and they are sitting, and even the pulse rate is quite normal. Do you have any explanation for that?
You know, I'm not sure if it's all theoretical, but there are some talks about basically the COVID-19 virus itself have some neurotropic effect, you know, affecting the brain stem, the way we receive the respiration sensation, and also affecting the, you know, vagal parasympathetic drive for, you know, bradycardia. So, you know, there are some neurotropic effects of COVID-19 virus, which could be beyond what we know at this point, but there are some theories that this could be one of the possible explanation. As you said, you know, patients hypoxic, but they just happy and their heart rate's fine, you know.
That's the end of my questions. Thank you very much.
No, thank you so much. Let's see, is there anything else? I think that as a chat, somebody asked a good question about would the surgery, if they do ever require surgery, would they get worse because of COVID? Would the surgery get their COVID course worse? And, I would say, in general, I think some of those patients are very inflated. So for example, I would give you a case we had where a patient had a tibial fracture and the patient had COVID-19 and he was sick, and we did not do the repair of the tibial fracture because if you do repair that fracture, there is likely more inflammation, and that could basically lead to, more, basically the course of COVID itself could worsen. So, I would say it's basically a balance between the benefits of the surgery and the risk of worsening the inflammation related to COVID. So, we usually try to avoid it unless it's needed absolutely to intervene on, does that make sense? I think that's what you were asking. Your question was more towards that. Good. Yes. So let's see. And somebody's asking, yeah, this is a good question. Somebody's asking is Dalia Dana asking a role of acute phase reacting and following the response of the management, or do you just depend on the clinical findings? And that's a very good question. We initially were following all the acute phase reactant, mostly CRP, ferritin, and D-dimer. And I think the D-dimer might guide you with your anticoagulation intensity, possibly. That's controversial. The CRP, we did check it initially every day and then later on every couple days, because usually if you haven't given IL-6 inhibition, which would definitely decrease your CRP, but if you haven't given that, usually the CRP drop means that likely the inflammatory phase of COVID-19 has improved and could give you a hint that, hopefully the worst is over, So we do follow it once in a while, but it really mostly depends on the clinical findings. Ferritin tends to lag behind. The drop in ferritin tends to lag behind the CRP. So we follow more CRP. And, the D-dimer, as I said, it's mostly for, guidance of anticoagulation intensity. Very good. I'm not sure if I'm missing anything else, but...
We made it all. Thanks for your time. We have only Kovan Fayaq. He's thanking you, and he's asking if you have more presentations and Zoom meetings for Kurdistan doctors, of course.
Yeah.
So
we'll be happy to. I think we love working with our colleagues back home, and we will be happy to. Myself and also my colleagues here, I'm sure they will be happy to arrange for more of those meetings.
Yeah. Thanks a lot, Dr. Abdul Hamid, for your time. Thanks, and special Kurdistan Health Summit, which is the aim is to collaborate and open dialogue between doctors from outside and inside to improve the education and improve research. So there will be definitely the contact between you and Dr. Abdul Hamid for further in future.
Sure.
Sure. Thank you very much.
Thank you so much. Bye-bye, guys.